All right. Well, good morning. Good morning. Let's get started. Okay. Lots to cover this morning. So very quickly, boy, this thing is very touchy. All right. So we always start with a few objectives, right? See if this guy works. There we go. So I would have you be able to list the most common causes of anemia in children and adolescents. And this thing, there we go. Of course, recognize that certain types of anemia are more or less common in certain age groups, right? We'll talk about that. You should be able to generate a differential diagnosis based on a combination of several things, but at least sort of synthesize age, MCV, and clinical history sort of all at the same time. Really points you in the right direction. And then be able to select appropriate tests to at least begin a workup of anemia, okay? At least sort of a first-tier workup of anemia. Okay, so I like to keep things simple, right? And I encourage everybody, use your common sense. Anemia, I think, is pretty straightforward if you keep it simple. Think in global terms, right? So do you have red blood cells that are being lost? Body is making them appropriately, but you're losing them, as in GI bleeding, menstrual loss. Both of these will usually, of course, present with iron deficiency. Do you have red cells that are being made appropriately, but then being destroyed, as in the case with autoimmune hemolytic anemia, in which case you should also have an elevated bilirubin, an appropriate reticulocytosis. Those are classic for hemolysis. Do you have hypersplenism, for instance? In someone with chronic liver disease with portal hypertension, right? Depends on sort of the area in which you practice, if you see a lot of those patients. Do you have red cells that are simply not being made due to lack of substrate, for instance, with iron deficiency? In that case, you should have a low reticulocyte count. Do you have transient erythroblastopenia of childhood, or TEC? This is a transient red cell aplasia, and you'll have almost a zero reticulocyte count with often a very low hemoglobin. Do you have marrow infiltration as the cause of your low hemoglobin, in which case your other counts are also likely to be affected if you have the factory is just being smothered by bad cells? Do you have aplastic anemia, in which case the bone marrow just decided to stop producing temporarily or permanently, in which case, of course, your white cells and your platelets should also be low, and you really should look for an elevated MCV in that case. In any case of aplasia, you should have an elevated MCV. Do you have red cells that are not being made correctly? That's why they're being destroyed, as in the case with hereditary spherocytosis, where you also should have an elevated bili and retic count. Okay, that is a membranopathy, right? Do you have red blood cells that are being made with the wrong hemoglobin or enzyme inside, as in hemoglobinopathies or enzymopathies, and thus they are hemolyzing, as in the case with, for instance, sickle cell, the thalassemias, G6PD as the most common example. Okay, now similarly, think about what's common, okay? We're always told don't go looking for things that are not the most common, because if you think this way, chances are you're going to land in the right spot. So think about the age and the clinical presentation. Infants less than 12 months, we don't see anemia a lot in this age group, but it happens. Iron deficiency is pretty rare, okay? Think about the situation that your patient is in. Are they purely breastfed? Are they formula fed? Should you or should you not be seeing a little bit of iron deficiency? Of course, think about their physiologic nadir if they're near that that kind of 8-10 week age range. Think about ABO or RH incompatibility if it's a newborn and you're rounding in the newborn nursery. Do you have a congenital anemia? They will show up in infancy. Do you have G6PD deficiency? Certainly, again, if you're in the newborn nursery and you have an elevated bili in a new male baby, a lot of people screen for G6PD. Do you have thalassemia trait? Could be alpha or beta, actually. Do you have leukemia? Of course, infant leukemia is very rare, but we certainly see it and shouldn't present with isolated anemia. Okay, you should see other abnormalities on their CBC. But now if we get into the toddler age range, I feel like the list gets a little bit longer. For sure, iron deficiency, very common in this age group, right? Limited diet, transitioning off of iron-fortified formula to regular milk. A lot of times they drink too much milk. TEC, right, that transient erythroblastopenia of childhood, very much a toddler phenomenon. Diamond-Blackfan anemia, which is congenital pure red cell aplasia. Hereditary spherocytosis kind of starts to show up in the toddler age range. Do you have a previously undiagnosed sickle cell patient? That happens. Do you have thalassemia trait? Often is picked up at the same time as screening for iron deficiency anemia. You have to sort those out. G6PD for sure shows up in this age range. And then I kind of started to add hemolytic uremic syndrome. You can see in this age range, definitely leukemia comes on the scene a little bit more than it does, for sure more than it does with infants. How about the school-aged kids, getting a little older than the toddlers? Iron deficiency, definitely possible, but again, you have to take a very good dietary history. It happens, hereditary spherocytosis for sure, that thal trait is still there. Now I add the autoimmune hemolytic anemia. This is pretty unusual in the littler school-aged kids, but if you start talking about 8, 9, 10, 11 years old, you can definitely see it. HUS still here, leukemia still here. Then you kind of start thinking about GI blood loss, right? You start thinking about inflammatory bowel disorders that may show up in this age range. And the later school age or adolescent patients, iron deficiency for sure, common in your menstruating females. Always, always, always think twice or 3 or 4 times about iron deficiency in males, okay? You shouldn't see that in a teen boy. That young man needs a GI evaluation quite promptly. Think about autoimmune hemolytic anemia in these patients, for sure GI blood loss, again, and leukemia, okay? This I don't put up here for memorization purposes, but just to remind you that the ranges for a normal hemoglobin are certainly different in different aged patients, okay? And always pay attention to what the norms are in your lab, okay? Boys that are getting older and making testosterone, right? They should have a higher hemoglobin than 7, 8, 9-year-old boys. So pay attention to the norms. And in this day and age, it really shouldn't matter what size medical center you're practicing in, small, medium, or large. They have, the laboratory should be changing that range based on how the age of the patient is plugged into the medical record. Okay, so again, super simple. Use the entire history and physical to your advantage, okay? If you ask all the right questions and you look for all the right things on the exam, I think you'll get to the right spot. Get a very specific dietary history, okay? And you've all heard this a million times. Examples of what they eat. Tell me what they eat for breakfast, lunch, and dinner. What do they eat for snacks? You're looking for, I'll tell you, and I'm finding in this era, I'd be interested to see what Dr. Flagg thinks. I feel like we're seeing almost a positive problem. We're seeing a lot of super healthy kids and families who are, I'm getting a lot of 8, 9, 10, 11-year-olds who are iron deficient. They're just healthy family eaters. They don't eat a lot of red meat. They don't ingest a lot of heme iron. So they have iron deficiency anemia with no other clear cause. They're not losing it anywhere. It's just good family habits. And certainly a lot of very fit teen athletes who are just really good eaters and failed to remember that they need to take iron supplementation as well. But ask about what they drink, right? How much milk? Show me, how big are the sippy cups? How many of those do they drink in a day? You'll be really quite stunned at some of the drinking histories that you'll get from these people. How much juice? How much water? Ask them specifically. Don't ask ounces. A lot of people don't know how many ounces are in a sippy cup, right? Just have them show you. Pica behaviors, come right out and ask. Parents will kind of look at you like you have 3 heads, but you have to come out and say, do you ever see your kid putting anything in their mouth that isn't food? Do they eat dirt, crayons, chalk, paper? Sometimes they'll do, toilet paper, or they'll dig out of the trash the cardboard that's at the end of a toilet paper roll. Kids will gnaw on that. And if their kid has been doing it for a long time, the parents don't see that it's any issue, right? Ask about living situation, right? Old home, new home. You're looking for the possibility of lead-based paint, right? Ask if they have chipping or peeling paint around their windowsills. Family ethnicity and any surgeries that their family might have had, right? So ask them, what part of the world does your family come from? And if you get, strong Mediterranean, oh yeah, we're purely Italian, then you might be onto a thalassemia trait, right? Ask about people who have had surgeries. Specifically, do you have people who have had their gallbladders taken out or had their spleens removed, okay? There may be people in the family who have been hemolyzing, and they may or may not know why they had those organs removed, but ask about it, okay? Frequent moves, I put this up there because this is how you miss a sickle cell patient, okay? If they're moving around frequently and they had an abnormal newborn screen and they were detected as having sickle cell, but nobody could ever find them, because they didn't have a valid address. Good neonatal history, right? You're looking here for possibly exaggerated anemia in the newborn period, maybe hyperbilirubinemia. Did your baby go under the lights? Did you go home and have to come back and go under the bilirubin lights, okay? Especially if all their kids have done that, they may just think, oh, that's what my kids do. Every time I go home, we always end up having to come back and go under the lights, okay? So ask about that. Good menstrual history, and again, I think you all know this, but it's not, are your periods normal, okay? Because there are women and girls in families who pass around von Willebrand's disease, for instance. They have very striking menstrual histories, very heavy menstrual bleeding, but because everybody in the family does it, they just think that that's what's normal for them, okay? So ask very pointed questions. It's uncomfortable for them, really uncomfortable if their dad is in the room, you know, but you gotta ask the questions. Pads or tampons, how many a day? Daytime accidents, nighttime accidents, the whole thing, okay? Good viral history. I put this in here, right, because that TEC, very much a post-viral phenomenon. So ask if they have recently had upper respiratory illness. GI blood loss for obvious reasons. Ask about medications, okay? Sometimes simple things like a medication that has triggered some hemolysis, for instance, in a G6PD patient, okay? So don't forget the simple things that should be a part of all the questions you ask, all right? Now again, simple physical exam. What are their vital signs, okay? If they have a very low hemoglobin, are they very tachycardic? Or are they not tachycardic? How long has this anemia been going on? What is their color? I put this up here, right? Because you're looking for either pallor, or if someone's hemolyzing, you're gonna see them a little more jaundiced, right? Color of their lips, conjunctiva is a good place to look as well. Do they have any organomegaly? Okay, do they have splenomegaly? Might point you in the direction of hemolysis, right? Do they have splenomegaly and hepatomegaly? And then a whole bunch of lymph nodes, and then you're thinking, uh-oh, do I have a new leukemia patient sitting in my office, right? If you have some patient with aplastic anemia, for instance, that's not a marrow infiltrative problem, right? So those patients have no lymphadenopathy, no organomegaly, okay? So just simple things really point you in the right direction. And then your simple labs, okay? So when you start with a hemoglobin, I just put out there, excuse me, how low? Is it a hemoglobin of 2, which takes you in one direction? Is it a hemoglobin of 9, which takes you in another direction? If you tell me someone has hemoglobin of 3 with an MCV of 45, I'm gonna say that kid probably has iron deficiency anemia until you tell me otherwise. If you say hemoglobin of 3, MCV of 80 in a toddler, I'm gonna say, that kid probably has TEC. If you say hemoglobin of 8 with that MCV of 80, I'm gonna say, ooh, that doesn't sound like iron deficiency. Is this kid hemolyzing? What's the retic count? What's the billy, okay? Again, indices. The MCV is really the one we look at the most frequently, right? Particularly in comparison to the hemoglobin. And you'll see, I think I comment on this, when you look at iron deficiency, your hemoglobin and your MCV should go down and it should feel like they're falling almost in parallel. If you have a hemoglobin that's slightly low, but your MCV is dropping in what feels like a disproportionate fashion, think about the thalassemia traits, okay? MCHC, I put on there, this is a favorite on the boards. It is elevated in hereditary spherocytosis, okay? So that's why I put that one there. I will tell you practically, it doesn't always work out that way, but for some reason, it likes to show up on your tests. And of course, look at a smear, okay? It's old-fashioned, but it's helpful, even if you're at a place where you know, most pediatricians, I will concede, don't do this. But there are people at your hospital who are trained to do this. They are hematopathologists, okay? Anywhere you work, there's a way to order a smear, have somebody who looks at blood and bone marrow all day, have them take a look for you, comment on the morphology, microcytosis, things of that nature. And always get a retic count. Okay, like I said, this really drives your thought process. Does the patient have anemia with an appropriate reticulocyte count? Okay, like that kid with hemoglobin of 8 and an MCV of 80, okay, mild normocytic anemia. If that kid has a retic count of 8, 9% and a billy of 3.5, I'm gonna say, boom, that kid's hemolyzing. If that kid has a retic count of 1%, which is normal, and a normal billy, you're on a totally different path, right? And I always just encourage people, because if it's not on your mind and you forget, that's fine. It goes in the same tube as a CBC. You can always call your lab and have them added on, okay? Especially if you order a CBC and then you're surprised by your result, kid's anemic and you weren't expecting it, you can always call the lab and have them added on, okay? And then again, other studies as indicated. Iron studies, if that's where you're headed. Bilirubin, of course, if you're looking for hemolysis. A Coombs, if you think you're in autoimmune hemolytic anemia territory, right? Say you've got teenager hemoglobin, again, we'll do that, hemoglobin of 8, MCV 80, and you feel a spleen tip on their exam, and they look a little bit yellow on their examination, and you think, what's going on here? Sure. Add a Billy, add a Coombs, see what you've got. Blood level, if the story fits, hemoglobin electrophoresis, if the story fits, and I say that with caution, only because it really depends on the patient age as in how much information you'll get from it. Dr. Flagg will be talking to you about that in a little bit. And again, this is really something that you should have seared into your brain eventually, but it's really helpful to be able to categorize these patients based on a microcytic anemia, normocytic anemia, macrocytic, of course. There are always exceptions, but generally speaking, if you can lump somebody into one of these lists, you're going to get very close. And then again, do you have an increased destruction problem versus a decreased production problem? Okay, look at your reticulocyte count. Does this person have an appropriate reticulocyte response to whatever is going on? If you have a kid with iron deficiency with a hemoglobin of 6 and an MCV of 65, and they're iron deficient, they don't have enough substrate. So if you check their reticulocyte count, it's going to be low, okay? And a lot of people will use a reticulocyte count to gauge the response to iron therapy, okay? So think increased production or decreased production, increased destruction, okay? Again, very helpful. And then with a lot of practice, you can sort of synthesize all this stuff at the same time. All right, so how about a few cases? Let's see. So a 19-month-old male, we'll say, noted by his grandmother, she thought to be pale and kind of fussy. He's described as very picky. Diet is very cheesy, mainly string cheese, a lot of mac and cheese, a lot of milk, and again, you'd be surprised. People will let their kids eat whatever they'll eat, and sometimes this is what you get. Child appears in no distress. He's a bit tachycardic, normal heart rhythm, no gallop, teeny bit of a murmur, good blood pressure, good perfusion. And his CBC, he's got a hemoglobin of 5, MCV 52, and a retic count of 1.6%. What would you say is the most appropriate clinical management for this toddler? Okay, good. The D's have it. Uh-oh, I went backwards, I'm so sorry. Right, so D is correct. Okay, so no clear indication that this baby needs to be transfused. He's clinically fine. And if you started him on a daily children's chewable vitamin with iron, that simply wouldn't be enough elemental iron to fix this kid's degree of anemia. Okay? So what about iron deficiency anemia? Again, toddlers, adolescent females, particularly susceptible for reasons we've talked about. This is an anemia of varying degree. Okay, it can be 10, it can be 2. You'll see a few of those in your practice. Low RBC number, low MCV, inadequate reticulocytosis, okay, because they have a lack of substrate. Classic labs, you're going to have decreased serum iron, and you'll probably, most labs these days also report percent iron saturation, that'll be low. You have elevated TIBC because you have increased binding sites for transport, and a normal to a decreased ferritin depending on when you caught this patient in the scheme of things. We treat this with oral iron, 3 to 6 milligrams of elemental iron per kilo per day in divided doses. I will say, people are always tinkering with this, and there's actually some interesting data out there that may suggest that we've been doing it wrong all along, and what people may benefit from is actually larger iron loads once or twice a week. It's all over the map. Works in some people, doesn't work in others. For our purposes, we're going to keep it like this. If you do 325 milligrams daily or twice a day in your adolescence, that can be good. Now, right, that over-the-counter ferrous sulfate, that contains about 65 milligrams of elemental iron. So you have to be mindful of how much your adolescent weighs and what you're dosing. I will tell you a fair number of iron deficiency consults that we get for what the pediatrician thinks is somehow refractory iron deficiency anemia, they have simply underdosed the patient, okay? If you have a teenage girl who weighs, let's say, 65 kilos, and she has a hemoglobin of 8.5, and the pediatrician puts her on 1 tab or even 2 tabs a day of this, that's 1 to 2 per kilo per day of elemental iron. That's just a simple underdosing error. Recheck the CBC with or without a retic count in 2 to 6 weeks. I put up there as, you know, it's random, depending on how low the hemoglobin is. If there's no change, right, consider compliance. Oral iron therapy is very difficult, depending on the age, whether you're trying to push liquid iron into a toddler, whether you're trying to do larger doses of iron in teenagers, the nausea, the constipation, the compliance can be very poor. If no obvious dietary or menstrual history to explain your iron deficiency, you really do need to rule out occult GI blood loss, okay? If you're struggling, you know, if you've got that toddler who just seems to have an amazing diet and still they show up with a hemoglobin of 7.5 and a low MCV and low iron, you better be looking for something else if the dietary history doesn't fit, okay? All right, which of the following sets of labs are consistent with iron deficiency anemia? Okay, good. So you don't even need to know what an RDW is to answer this, right? Because you would know that you have decreased RBC number and a decreased MCV. Your RDW, though, it's really nice because it should go up in iron deficiency anemia. It's your red cell distribution width, right? And it's that machine counter counting red cells of varying diameters, okay? So when you capture someone with low iron, you'll have some normally hemoglobinized cells. They're sitting in the middle of the range. You have a few bigger ones that were some decent retics that they pushed out before they ran out of substrate, so then you got the bigger cells. Then you got the little tiny guys over here that are the poorly hemoglobinized cells. So you're gonna have a wide range of diameters that drives up your RDW. In theory, it's helpful when you are trying to distinguish iron deficiency anemia from thalassemia trait, okay? Generally speaking, if you have thalassemia trait, your RDW should be right around normal. They're making teeny tiny cells, but they're all the same size. So the machine is not picking up cells of varying diameter, okay? And again, we commented, marked discrepancy you will find between hemoglobin and MCV if you have thalassemia trait. Now, the problem is they can coexist, okay? And this happens a lot. You'll pick up a kid who has iron deficiency anemia and they have thalassemia trait. Well, that's fine, you're stuck. You just have to fix the iron deficiency anemia, see where everything lands, and investigate the thalassemia piece later. Okay, what do we have now? Previously healthy, again, 19-month-old boy, gradually develops low appetite, decreased activity, hemoglobin of 5.1 with a retic count. Someone grabbed a retic, less than 0.1%, white count 4.5, platelets 440,000. MCV is normal at 80. It's the most likely diagnosis. Okay, great. So if you describe this boy, you would say he has isolated, moderate to severe normocytic anemia, right? And that fits absolutely with transient erythroblastopenia of childhood, all right? It is transient, as the name implies, self-limited red cell aplasia in contrast to diamond black fan. Okay, this is a congenital problem. Some of the kids with diamond black fan burn out, some do not. This typically lasts for a few weeks. Again, very much a toddler phenomenon, 1 to 4 years old-ish. Again, you can have some very striking hemoglobins in these kids. Nearly an absent reticulocyte count. These kids should have a normal MCV, okay? As opposed to the kids with congenital pure red cell aplasia, diamond black fan, that's a bone marrow failure syndrome. If you have a kid with a hemoglobin of 3 and an MCV of 105, as opposed to 80, you'd be thinking more about diamond black fan in that kid. Some people will note a little bit of neutropenia that happens at the same time in these kids, not necessarily. A typical clinical course is 1 to 2 months duration. Sometimes they need transfusion support, depending on how low their hemoglobin is. Of course, you can't just have a kid with a hemoglobin of 3.5 and a retic count of 0. Even if they look great, you can't just sit on that kid, right? They are going to need some help until their bone marrow turns back on. And again, treatment doesn't affect time to recovery. This is not a recurring phenomenon. You tell them this doesn't necessarily happen in siblings, okay? It's just kind of one of those unusual phenomena. Diamond Blackfan, on the other hand, this is a progressive normochromic macrocytic anemia detected usually in infancy or early childhood. By far, the majority of these kids are diagnosed by age 1. Many of them have some, as a lot of the congenital marrow failure disorders that we see, like Fanconi anemia, for instance. Some of them, this is why you have to do a good physical examination, right? Some of these kids will have some physical anomalies that will point you in that direction. Some of them don't, I will say. The few Diamond Blackfan kids I've had over the years, none of them have had any other physical anomalies. So these kids, of course, just like the TEC kids, they have reticulocytopenia, elevated red cell adenosine deaminase is how we look for this. We'll also look for a fetal hemoglobin that is elevated in these patients. Normal cellularity of the bone marrow, they have everything going on. They just have markedly decreased or even absent erythroid precursors when you marrow them. These kids can be treated with steroids with some success. Many of them are transfusion dependent. If they're not, you can wait it out and it might burn out. Stem cell transplant, certainly in these kids, is curative. Okay, now what do we have? 2-year-old girl, noted to have prolonged neonatal jaundice, found to have a palpable spleen tip in your office, and she has the following labs. So hemoglobin of 10, a little bit low, retics 5.6, white count 6,000. We'll say she has a normal diff. Platelets 320,000, MCHC 37, which is a teeny bit high, MCV 82, and an RDW of 19. Which of the following do you think will help in the diagnosis? Okay, well, the answer here is definitely all of the above. So what does it sound like this girl has, do we think? Anyone? Hereditary spherocytosis, right? So the EMA binding assay is kind of our new favorite way to look for that. It's sort of replacing or being done in conjunction with the osmotic fragility test. If you look at the smear, that is going to be helpful, right? You're going to see some spherocytes on the smear. A careful family history, right? Because hereditary spherocytosis is most often, but not always, autosomal dominant. Okay, so usually you can find some family members who have been experiencing the same thing. And if you look at a smear of the parents, you know, sometimes that's what we do. If we have infants and we really want to know what's what, we are limited in the amount of blood that we can take from some smaller ones, right? So sometimes we'll do blood work on the parents and see what we find. Okay, so this is the most common, actually, inherited hemolytic anemia. Again, this is a membranopathy. This is a defect in your red cell skeletal membrane proteins. These are, of course, non-deformable spherocytes that are destroyed in the spleen. They are not nice, deformable biconcave discs, right, like a gummy saver. These are more like, you know, tiny gobstoppers. They can't get through the microvasculature of the reticuloendothelial system. Varying degree of anemia, again, increased bilirubin, increased retic count. Typically, you should see an elevated MCHC, which we sometimes do and sometimes don't. Again, close attention to family history, patients and the siblings' neonatal history, okay, because maybe the siblings did it too. There are people wandering around with mild hemolysis that's just not clinically significant for them, okay, so maybe nobody knows about it. This is a chronic stable hemolysis marked by periodic exacerbations that are often, but not always, post-viral. So if these kids do end up with a viral illness that kind of dings their red cell production a little bit, they can sort of get into some trouble with a lower hemoglobin than they can handle if they lose that reticulocytosis. Again, confirmatory testing can be tough on the younger patients. Now that we have flow cytometry-based testing, which is the EMA testing, that makes the testing more reliable in littler kids. If you don't need to know when they're little, it's okay to wait it out. But again, sometimes we need to test the parents. No therapy is needed for these kids. They should be on some extra folate, a little bit of iron supplementation, right, to support their reticulocytosis that they are engaged in all the time. Unless they have a history of frequent and severe hemolysis, repeatedly dipping below 5 or 6 and requiring transfusion support, they can certainly benefit from splenectomy if we can try to drag our feet on that until at least age 5. Okay. So how about this one? Hereditary spherocytosis may be associated with all of the following, except what? Hope everyone gets this one, right? They should have an elevated MCHC, right? Okay. That was your easy one for the morning. Okay, how about this one? 2-year-old boy, he's allergic to penicillin and cephalosporins, common story, right? Presents with pallor and irritability 1 week after being treated for an otitis. The family is from Persia. Exam is notable for a little bit of pallor. He's got a nice Mediterranean complexion. His hemoglobin is 6.2, MCV 82, retics are 6.8. Which of the following is false regarding his likely diagnosis? Okay, good. So what does this boy probably have, you think? G6PD, right? These are always the bummer questions on the exam, right? Like you know what the answer is, what does he have? And then what they ask you is actually not what's the diagnosis, right? So you know this kid probably has G6PD, and it is true that, or false rather, in this case, that only viral illnesses are known to precipitate hemolysis. Anything can do it, okay? No, not just viral illnesses. How about this? A 9-year-old boy presents with a history of fatigue, pallor, a little bit jaundiced. He's recently been treated for pneumonia, okay? His peripheral smear shows some red blood cell agglutination. What is his most likely diagnosis? Okay, well, the majority has it. So this is a classic finding, right? Cold IgM, autoimmune hemolytic anemia. This kid probably has what organism? Anybody? Mycoplasma is the one that does this most frequently, right? Okay, so autoimmune hemolytic anemia, this can happen in any aged patient. As I said earlier, I think it's more common in sort of school age and above, okay? Anything's possible, but I would say more commonly the kids who are a little older. This is typically a normocytic anemia, sometimes dramatic. Again, you can pick up a kid who's got mild hemolysis, hemoglobin 7.5, 8.5. We can see these kids show up with a hemoglobin of 3, 4, 5, okay? They should have an elevated bilirubin. As a result, they should have an elevated retic count, okay? Hemolysis, it's defined by a good, robust reticulocyte response, okay? And a positive direct Coombs, right? This is searching for the presence of antibody attached to the red blood cells. You may get a viral history that precedes an episode of autoimmune hemolytic anemia. Not always, but again, good thing to ask when you're taking a history. This doesn't tend to happen over a long period of time. They will have some amount of pallor depending on how low their hemoglobin is, how high the bilirubin is. You may detect a little bit of jaundice, right? So important to pay attention to what color you're dealing with. You should have splenomegaly, okay? I would say for sure, more often than not, you will detect that. They may actually be doing some of their hemolysis in the liver as well, but I would say more often than not, you detect some splenomegaly. Just the warm versus cold, a simple slide by far. The warm autoimmune hemolytic anemia, much more difficult to deal with, right? Because that's happening at body temperature, so we have a harder time dealing with that. This is an IgG-mediated phenomenon. This hemolysis is happening more in the spleen than the liver, so if we end up with a very bad case of warm autoimmune hemolytic anemia that we can't control with medications, these kids can benefit from splenectomy ultimately. Cold autoimmune hemolytic anemia, typically IgM, this is happening more often in the liver. These patients by far do not behave as badly as the warm people. That's usually a self-limited phenomenon, the cold autoimmune hemolytic anemia. How do people know these things? This is your blood bank, tells you, okay, what is mediating your cell destruction. Not something you can just tell by looking at a CBC. This definitely needs subspecialty attention. I don't recommend any primary care physicians dabbling in autoimmune hemolytic anemia. It can get very complex. Steroids, sometimes IVIG, some heavy immunosuppressants, splenectomy. There may be other underlying things that we're going to find, and the autoimmune hemolytic anemia is just a presenting feature of something. Lymphoproliferative disorders, things of that nature. Very difficult transfusions because they have autoantibodies, so it's very difficult to get them a good blood transfusion. If you're lucky, it resolves on its own. Sometimes it does. I would say more often than not, it does not. Okay, I think that's it. I must have talked quickly, so we'll move on.